Hello, sir.
Sir, Principal, sir. Good evening, sir.
Vijay Kumar, good evening.
Good evening, sir.
Sir,
ఏమండి
clear గా వినిపిస్తుందా సార్? నా వాయిస్ వినిపిస్తుందా సార్?
మీ వాయిస్ చాలా క్లియర్ గా ఉంది విజయ్.
ఓకే సార్. సార్ స్టార్ట్.
వి కెన్ స్టార్ట్. చూడండి క్లియర్ గా ఉంది, ఇట్స్ క్లియర్.
ఓకే ఓకే ఓకే. కార్తిక్ సార్ స్టార్ట్ చేద్దామా సార్?
Yes, sir. One second, sir. I think there is some problem with my lighting. Yeah. Okay, sir.
Dr. Karthik sir, good evening.
Good evening, sir.
Nice to see you, sir.
Just came back. One second, sir. Let me just see if I can do something about this light. Is it okay, sir? The quality, the video?
It's okay, sir.
Oh, okay, sir. Okay.
Hello everyone. This is Dr. G. Vijay Kumar from KVSR Siddhartha College of Pharmaceutical Sciences. Welcome to the webinar on ECG Made Easy by Dr. Karthik Naidu, cardiologist from Pinamneni Siddhartha Institute of Medical Sciences, Pedotapalli, Gannavaram, Vijayawada, which is organized by Department of Pharmacy Practice, KVSR Siddhartha College of Pharmaceutical Sciences, Vijayawada. Good to see you and lovely to meet you all on this webinar platform and Zoom platform. Why? The reason for selecting this topic is we, the pharmacists, being the experts on the drug therapy, you need to know how different drugs exerts their effects on electrical system of the heart. Pharmacist review of ECG is a relatively straightforward when you compare to the other pharmaceutical professionals. Definitely, and I feel interpreting ECG by the pharmacist is a useful clinical skill required nowadays. We should be able to interpret the rhythm of the heart and calculating the heart rate and different drug toxicity on the ECG and QT intervals, PR intervals, whatever it may be. Being a pharmacist, we should not worry the what type of solids and where to place and which part of the heart is placed, which lead is placing which part of the heart. We should not mind. Just only we need to learn about the
Vijay Kumar. Vijay Kumar.
network.
Jay?
Like,
Vijay Kumar?
sir. Yeah, yes. The pharmacy profession never changing, evolving like anything. Being a pharmacist, I strongly feel that we should know everything about the ECG. And although the pharmacists have a limited role in diagnosing of the disease such as the ECG, other diagnosing diseases, but we should. I strongly feel we should learn something basics about the ECG. That's the reason we requested Dr. Karthik Naidu to address these issues. It is greatly useful our pharmacy students, especially the pharmacy students and the pharmacists who are working in the hospitals. I all the pharmacy fraternity utilize this opportunity, make familiar with the interpreting of the ECG when you are facing when you are going to the ward rounds. Definitely we can take part in the drug making decisions, therapeutic, and we can improve the drug therapeutic outcomes, and we can practice rational drug therapeutic use. And now I request our beloved principal, Dr. Deval Garu, to brief about our today's speaker, Dr. Karthik Naidu Garu, and start the proceedings.
Thank you, Dr. Ganta Vijay Kumar. Good evening, all the participants. Dr. Karthik Naidu, KC, and all the participants. Very good evening to all of you. I am very happy. Our Dr. Ganta Vijay Kumar, HOD of Pharmacy Practice, he has arranged a nice talk on Ecg Made easy by an eminent and very young doctor. He is very highly talented also, highly academician also, who is none other than Dr. Karthik Naidu, KC, who is working as assistant professor in Phenomenally Siddhartha Institute of Medical Sciences, so in our sister concern only. And coming to Dr. Karthik Naidu, we know him for the last 3 years. He is very talented, no doubt. He has completed MBBS and then MD General Medicine. After that, DM Cardiology and MB also. All the 3 degrees in medicine he has completed from Rajiv Gandhi University, Karnataka, and he has done MBA abroad. After that, he has presented several papers in conferences in India and abroad also. And for the last 3 years, we are observing also all our pharmacy students, they are going to ward rounds in our Phenomenally Siddhartha. He is giving a lot of guidance to our pharmacy students. For that, we are very happy, sir. And today evening, even though I think all of you know it is 7 to 8, I don't feel it is odd. It is correct time only, because now it is not a time to go out, because earlier 7 to 8 means almost all we used to go outside and we used to enjoy outside. But for the last 5 months, I think you know the situation throughout the globe actually. Therefore, we cannot go outside. Definitely, I can feel that it is the right time to have what is called interaction with Dr. Karthik Naidu, KC, from Phenomenally Siddhartha Institute of Medical Sciences. With these few remarks, I request all the participants to utilize the webinar going to be presented by Dr. Karthik Naidu, and definitely it will be a very useful interaction only. With these few remarks, now I request and welcome Dr. Karthik Naidu Garu to start his presentation. Thank you, sir.
Sir,
Thank you very much,
just
Principal,
before starting the session, instruction for the participants, I request all the participants mute your video and audio. If you have any queries, please do not raise and please do not interrupt, and drop your queries in the chat box later in the session of soon after finishing this session. Thank you. Sir, please start, sir.
Thank you very much, sir. Sir, now I have a small request. Sir, can you just activate the share screening mode for me?
Yes, yes, yes.
Yes, sir.
Naishita.
చూస్తున్నాను సార్.
Now it's active, sir. Yeah. So can everybody see the screen now, sir?
Yes, sir. Yes, sir.
So can you just activate the share screening mode for me?
Yes, sir. We are able to see, sir, very clear.
So, yes, yes, sir. It's very clear, sir.
Okay, sir. So good evening, dear friends. I'm Dr. Karthik, Assistant Professor from the Department of Cardiology, Pinnamneni Siddhartha Institute of Medical Sciences. So as told by Sir, I very much agree that in today's world, where the cardiovascular diseases are increasing by the day, and a lot of people are coming with complaints of chest pain. So it becomes very important that everybody, especially those who are connected to the medical field, including the pharma students who are closely associated with us in our day-to-day clinical activities, they should also have an idea about the ECG. Understanding ECG, although it may be a very difficult task for a beginner, but there is a systematic way of approaching towards understanding of this ECG and how to read this. And if you learn that systematic approach, I'm sure that you will be an expert in an ECG within a year. So the objective of this session is basically so I do not have any disclosures or conflict of interest. And the object or the overview of our session would be to start with you with a brief introduction on the ECG, and then we shall learn about the various components of an ECG, the waves and the intervals. So to start with, what is an ECG? In fact, it can be considered as one of the most remarkable tools which was designed or developed in the last decade, which has helped save millions of lives. It has great clinical power in diagnosing critical cardiac conditions well in time and intervene and save the life before it's too late. On a single glance of an ECG, we can diagnose conditions like a myocardial infarction, life-threatening arrhythmias, pinpoint the chronic effects of sustained hypertension, acute effects of massive pulmonary embolism, and reassure someone in case if they want to know the health status of their heart. So to a beginner, when we flash an ECG strip, it almost looks like a music orchestra. Quite confusing at the beginning, but once you start learning it, you play by the tunes. So my advice to all the residents or the pharma students, whoever is witnessing this program, is that don't get scared when somebody flashes an ECG in front of you. Rather, just have an analytical approach to understanding the ECG. It's a very straightforward process, and if you follow those points as steps in a sequential order, you will never miss a diagnosis. So let us march towards understanding this remarkable tool of ECG. So to understand the ECG, we should know about a little brief about the hardwiring of the heart or the electrical circuits of the heart. As we know that the heart has got 4 chambers, the 2 atria and the 2 ventricles, right and left each. So there is a sequential flow of blood from the atria, the upper chamber, to the ventricle, the lower chamber or the pumping chamber. So the impure blood or the deoxygenated blood flows from all over the body, reaches the right atria, and from the right atria, it reaches the right ventricle across the atrioventricular valve, or also the tricuspid valve, from where the blood is pumped into the lungs through the pulmonary arteries, where the deoxygenated blood, it picks up oxygen from the lung tissue and reaches the left side of the heart, again to the atria through the pulmonary veins, and then the blood flows from the atria into the left ventricle, which pumps the whole blood into the circulatory system through the aorta, which is the great vessel. So with this description, you can see that the whole sequence of events that is happening here is quite synchronous and systematic. So how is the synchronous and systematic events brought about? So this is through the hardwiring of the heart, the electrical circuit. Since the heart is a muscle, it cannot contract on its own. It needs an electrical stimulus. And this stimulus has to be very sequential. And to bring about this sequential stimulus, we have a pacemaker which is located in the right atria, which is called as the sinoatrial node, because that acts as the battery power source of the heart, which is responsible for the continuous beating of the heart. Once the electrical impulse is generated by the sinoatrial node, the impulses travel from the sinoatrial node to the atrioventricular node. And after a brief relay from the atrioventricular node, they reach the ventricles, thus stimulating the ventricles to pump the blood. So this whole sequence of events which happen, they happen in a very sequential format. If you see in this diagram, you can see that at 0 seconds, sinus node is activated, and at 30 milliseconds, the impulse is almost reaching the AV node. And after a brief delay, at 160 milliseconds, the impulse travels down the AV node to the bundle of His, and then the right and the left bundle branches, thus stimulating both the right and the left ventricle. Even the stimulation of the right ventricle and the left ventricle should be very synchronous. Any dysynchrony on a long run would result in weakening of the heart muscle. So how is this electricity flowing? So if you are a physiology student, you would have already studied about this, where it is shown that the slight depolarization in a membrane of the sinoatrial node generates the electrical impulse, which flows in a very sequential manner from one cell to other cell. And once it reaches the cardiac myocyte, being a syncytium, so it spreads the impulse very rapidly across the entire musculature of the heart. So coming to the electrocardiogram. So electrocardiogram, basically it records the flow of these electrical impulses in the heart, and it studies if there are any abnormalities or deviation from the normal. So in an EKG wave, if you see, you will have a wave or an interval. The wave has got three attributes that need to be studied, which is the duration, the base or the width of the wave, the amplitude, which is the height of the wave, and the configuration, which is the shape of the wave. So a simple analysis of these three attributes of a waveform can give you plenty of information about the health of the heart, or the anatomical design or the structure of the heart. So on an EKG paper, the width or the duration is along the horizontal axis, and the amplitude is along the vertical axis. Excuse me. Yeah. So now let us follow the ECG changes that happen in a single normal cardiac cycle. So this figure here, in brief, demonstrates everything that I discussed just now. So on the top of the figure, you can see that there is a simple depiction of an electrocardiogram, which represents a single cardiac cycle, which consists of a P wave, followed by a brief duration or an interval, which is called as a PR interval. Then followed by that is a QRS complex, the ST segment, and the T wave. So what is happening in these waves? Why are they named like that? If you see, they are all related. All these waves precede the mechanical events of the heart. So what we are recording on ECG is the electrical events, and in the figure below, we can see the mechanical events of the heart. So these waves, the electrical events precede the mechanical events of the heart. So when you say that there is a P wave activation, it means that the ventricles are in a phase of diastole, which means that So am I audible now?
Yes, sir, you're audible.
Very clear, sir. Audible, sir. Clear,
Because I
clear.
think there was some signal problem. Suddenly everything jammed, nothing was moving. Okay, I'm sorry. Yeah. So let us follow these ECG changes in a single normal cardiac cycle. So as I was mentioning, that with the activation of the atria, which is represented by a P wave on the EKG paper, the atrial contraction takes place and the blood is emptied into the ventricles, which are in a phase of diastole. Now, the impulses travel from the atria to the AV junctional node, and after a brief relay, the impulses traverse across the bundle of his into the right and left bundle branches and activate the ventricles. So we can see that after the onset of the QRS complex, the ventricular systole is starting and the ventricles are contracting to eject the blood. Now, the whole process is taking about 80 milliseconds approximately, plus or minus. Now, repolarization, the ventricular repolarization starts and the ventricles are slowly starting to relax until the semilunar valves close and the ventricles enter into the phase of diastole back again. So this is the mechanical events that is depicted, which follows the electrical events on the ECG paper. And if you do a pressure tracing, you can see that the pressure changes in the aorta, there is a gradual decrease in the aortic pressure change, which is represented with a green line. And let us follow the red line, which is the ventricular pressure tracing. So as and when the ventricular systole starts, we can see that there is an increase in the pressure in the intraventricular chamber. And then at one point, the blood starts getting ejected into the aorta and it forms a curve. And towards the downfall of the curve, once the pressure inside the ventricle falls below that of the aorta, the semilunar valves close and the ventricles enter into a phase of diastole. So this is the pressure tracing. So we can see that this whole thing, the pressure curves, the mechanical events, electrical events, everything is synchronized and organized. So with this brief review, as I've already shown, what are the key components of understanding an ECG? Let us start analyzing an ECG. So what is that you would like to do when you get an ECG paper in your hand and you are asked to analyze the ECG paper? So first and foremost, for a beginner, it's always important to know that they should understand the calibration of the ECG paper. The ECG calibration, which means the horizontal axis, which represents the time scale, and the vertical axis, which represents the voltage scale, should be calibrated according to the standard guidelines. The paper speed being set at 25 millimeters per second, and the voltage 1 millivolt is equivalent to 10 millimeters of 10 millimeters on the vertical axis scale. So after ensuring that the ECG standard settings are set at a standard speed, then you have to start understanding and analyzing the ECG. So at usual paper speed of 25 millimeters per second, the rate of the heart is calculated as follows. Each small square, when the paper is moving at 25 millimeters per second, which consists of 5 big squares or 25 small squares of 1 millimeter each. So each millimeter becomes, each millimeter projects a duration of 0.04 seconds, which is 40 milliseconds, and a 5 millimeter big square represents 200 milliseconds or 0.2 seconds. Now with this data, we can calculate the rate of the heart, where we have 3 steps. Suppose if the rate is regular, we have two techniques to employ. One, either we can use the small square to calculate the rate of the heart, or we can use the large square to calculate the rate of the heart. So for a fist, if we are using the large square, we have to see that for a 300, which is an arbitrary number chosen, which represents a 60-second duration or a 1 minute duration, which becomes the numerator. And on the denominator, we calculate the number of Raj squares that are present between the 2 RR intervals of an EKG paper. So on the 2 successive beats, you find one R interval and the second R interval and calculate the number of large squares. divide 300 by that number. That gives you the rate of the heart. Sometimes it's very tricky. The two RR points may not fall exactly on the same, it may not give you the numerically satisfying or gratifying large squares, with small squares being left out. And sometimes the rate is so fast that you may not be able to use the large squares efficiently to calculate the rate of the heart. So in these situations, you can use the smaller squares, in which case you have to divide by 1500. So you use 1500 on the numerator and calculate the number of small squares that occur between two RR intervals and divide it to calculate the rate of the heart. However, for very slow rhythms or irregular rhythms, it becomes a little bit more trickier because the RR interval keeps varying from a beat to beat. In these situations, there are two techniques again. You use the rhythm strip, which is the lead 2 on a 12 lead standard ECG. You will see that there is a rhythm strip which is taken at the bottom of the ECG paper. So you earmark that rhythm strip and calculate the number of squares that fall for 6-second duration, which will be approximately 30 large squares. So on that distance, you calculate the number of complexes, that is the RR intervals that are falling under 6-second duration, and multiply it by 10. That gives you the heart rate for a 60 seconds duration or 1 minute duration. On the contrary, if you have a large rhythm strip, you can use this to calculate for 10 seconds and multiply it by a factor 6 to get the heart rate for a 60-second duration. Now, why do you need to calculate the rate of the heart? So it is very important to know whether the person's heart is beating within the normal range, or is it too fast, or is it too slow. To know that, you should know what is the normal range of the heartbeat. The heart beats at 60 to 100 beats per minute in an adult, and anything more than 100 is considered as tachycardia, and less than 60 beats per minute is considered as bradycardia. However, in children, the heart rate is slightly on the higher side, especially in the newborn. The heart can beat as fast as 110 to 150 beats per minute, and by 6 years of age, it attains the adult standard of 60 to 100 beats per minute. So having quickly calculated the rate of the heart on an ECG paper, we go next to the rhythm of the heart. The rhythm is a very tricky situation, which is very important to know, because just by looking at the ECG, its rhythm and the rate, you can diagnose some of the lethal arrhythmias in a flash of a second. So the rhythm is first best analyzed by using the rhythm strip, which is the lead 2 on a 12 lead ECG. Usually it is taken and represented at the bottom for a 12 channel lead ECG. And you have to see the rhythm strip and corroborate the findings by looking at the other leads. So once you know that a rhythm and rate has to be calculated, you have a quick 7-step approach for most of these ER physicians, where they can potentially diagnose many arrhythmias by quickly looking at that. So in this 7-step approach analysis, first we see the rate to see whether the patient has got a tachycardia or a bradycardia. Then we see the pattern of QRS complexes. So we'll be discussing in detail about the QRS complex in the next few slides, but here you need to know the pattern of the QRS complexes, whether the QRS complexes are happening at regular intervals or they are occurring at irregular intervals, whether the RR variation is regular or irregular. If it is irregular, is it happening at regularly irregular intervals, or is it irregularly irregular? That means the extra event, whatever is happening, whether it is with tachyarrhythmia or bradyarrhythmia, is it happening at recurrent intervals after few fixed beats, or is it happening at random events, as random events? Next, we look at the QRS morphology. So the morphology of the QRS means whether the QRS is narrow or is it wide. Because if it is narrow, then suppose if the patient is having a tachycardia, probably the origin of this tachycardia is either the sinus node or the atria or the junctional. If it is wide, especially in case of tachycardias, we can know that the origin of these tachycardias is either at the ventricular reverse, or if it is above the level of the ventricles, there can be some aberrancy. Then we look at the P waves. Now, the P waves and the PQRS relation is very important to diagnose some of the very important ECG diagnosis. Suppose if the patients have absent P waves, it could be either because of sinus arrest or it could be atrial fibrillation. So many of you, especially the PharmD students, during the clinical rounds, they would have witnessed ECGs where they have atrial fibrillation. So the first thing you see whether there is a P wave or not in those ECGs. And the second thing you see is whether the QRS complex is narrow and what is the rate, whether the rate is too fast or is it within the normal range. And if the P waves are present, so the morphology of the P wave and the PQR relationship becomes very important. Now, the fifth point you should understand while analyzing an ECG for rate and rhythm is the relationship between the P and QRS complex to know, especially in case of bradyarrhythmias, whether there is any AV dissociation. So when we talk about heart blocks, we know that PQRS relation, we have grade 1, first degree, second degree, and third degree heart blocks. In first degree, there is mere prolongation of the PR interval. And the second degree, there are two variants again, Mobitz type 1, Mobitz type 2. And apart from that, we have even advanced degree heart blocks and all those things. So the PQRS relationships to differentiate between the two entities, because that gives us important clue on future management of the patient. And if it is AV dissociation, then it becomes a third degree heart block, where P waves are beating independently and QRS complex are beating at their own independent rate. There is no correlation between the atria and the ventricles. However, in some cases, there can be an intermittent capture where a P wave is followed by a QRS complex. And the sixth point that you should understand on these ECGs is sometimes, especially when you come across a patient with a supraventricular tachycardia, as soon as you diagnose, you may be looking at the ECG and suddenly the tachycardia may disappear, or suddenly the tachycardia may reappear. So these kind of behaviors on an ECG, when documented, it becomes very important for the diagnosis of the entity. And apart from that, in supraventricular tachycardias, some people may try to do vagal maneuvers. So when you do a vagal maneuver, especially the supraventricular tachycardias, they either abruptly terminate or they do not respond. However, atrial flutter the maneuver is performed and then they revert back to their normal rate as soon as the vagal maneuver is stopped. Ventricular tachycardias, they do not respond to vagal maneuvers. And similarly, the sinus tachycardia, ectopic atrial tachycardias, they only briefly respond to these vagal maneuvers. However, I would like to exercise a caution at this point, especially when you're doing the vagal maneuvers, because especially in elderly, without auscultation, you should never do a vagal maneuver. Because when you don't auscultate and you miss a bruit here in the carotids, while giving a vagal maneuver, you may be at a potential hazard of inducing a stroke to the patient. So now let us understand some of the differences between the narrow QRS complex tachycardias. So narrow QRS complex tachycardia itself means that the tachycardia is originating above the level of the ventricles. So when it is originating above the level of ventricles, we need to know whether it is at the atrial level or is it at the atrioventricular nodal level. So if it is at the atrial level, whether the rate is regular or irregular. If it is regular, the most common cause could be just a sinus tachycardia due to anxiety, physiological stress, exercise, sports and recreation, or it could be just an atrial tachycardia, which can occur during the episodes of fever. And apart from that, there are other conditions like atrial flutter, sinus node-related tachycardia, and inappropriate sinus tachycardia. If the rate is irregular, then this points more towards pathological entities like atrial fibrillation, atrial flutter with varying block, and multifocal atrial tachycardias. If the narrow QRS complex tachycardia is at the atrioventricular level, we have three entities. One is AVRT, AVNRT, and automatic junctional tachycardia. Now, with this small theoretical background, let us go to the first illustration of a narrow QRS complex supraventricular tachycardia. So in the first ECG, the first illustration, we can see that there are two ECG waveforms. In the first waveform, we can see that the RR interval, there is tachycardia, but the RR interval is varying. So it is, the QRS complex is narrow, there is tachycardia, and the RR interval is varying. It is irregular. So we know that we are dealing with a supraventricular tachycardia. Now look at the P waves in that ECG strip. The P waves are quite prominent. They look like a sawtooth. So when they have a prominent P waves like a sawtooth appearance with varying interval RR intervals, usually the diagnosis goes towards atrial flutter with variable block. And if you see the bottom illustration, you can see again there is a narrow QRS complex tachycardia. The narrow QRS complex tachycardia with absent P waves. We don't see any P waves there. You see on an ECG strip. You should quickly think of atrial fibrillation as one of the diagnoses unless disproved otherwise. In the next illustration, we can see again it is a narrow QRS complex tachycardia. The RR interval is varying. The heart rate is very fast. If you employ the conventional techniques, you can see that the heart rate is close to 180, 190. And as a beginner, sometimes you may have a confusion to discriminate between whether it is a regular RR interval tachycardia or an irregular RR interval tachycardia. But if you see closely, definitely there is irregularity between the RR intervals. And then the moment you know that the step one, it is a tachycardia, it's a rhythm strip, irregular rhythm, and the patient has varying RR intervals, so it's an irregular rhythm with tachycardia. And then you start jumping at seeing the PQRS relationship. So we can see that there are P waves, there are quite prominent P waves, but there is discordant PQRS relationship. The P, that is the atria, they are beating at their own rate, and at a very fast rate, some of these impulses are conducted across the AV junction and stimulating the ventricles, which are again beating at their own rate, at a different rate. So there is a discordance between the rate of the atria and the rate of the ventricles. So this is an atrial flutter again, because the P waves are prominent. Now this is an example of atrial tachycardia. You can see that in the first illustration, there is a narrow QRS complex tachycardia. There is a P wave, which is followed by a QRS complex, and suddenly the tachycardia terminates and it reverts back to the sinus rhythm. You can see the duration of RR interval has gradually normalized. In the bottom illustration, we can see another illustration of a paroxysmal supraventricular tachycardia, where there is extreme tachycardia. The heart rate is close to 190 to 200 T waves, and the tachycardia has narrow QRS complex tachycardia. Now, with these brief illustrations on narrow QRS complex tachycardia to give you an idea, so when it is a narrow QRS complex tachycardia where the pathology could actually lie, let us move on to the broad QRS complex tachycardias. In the broad QRS complex tachycardias, again, we have two entities. One is regular tachycardias with regular rhythm and tachycardias with irregular rhythm. The tachycardias with regular rhythm include ventricular tachycardia, orthodromic, antidromic atrioventricular reentry tachycardia. The terms may be confusing, but you have to understand that ventricular tachycardia, which is most common, especially in patients with myocardial infarction, is what you need to diagnose immediately to save a life. Others you may find difficulty, but still, with a little application of concepts, you can arrive at the diagnosis. Then we have any regular supraventricular tachycardia when it bypasses the normal channels of electricity conduction and uses an aberrant pathway, bypassing the AV node and reaching the ventricles directly. So when that happens, those tachycardias can also have wide QRS complex. In some instances, when there is a supraventricular tachycardia, the rate is so high that the bundle branches, that is either the right bundle branch or the left bundle branch, they may temporarily cease to conduct the electrical impulses, resulting in rate-related bundle branch block, in which case again you can have white QRS complex tachycardia. We have differentials of ventricular fibrillation, polymorphic ventricular tachycardia, torsady points. So after this torsady pose, we have atrial fibrillation, which can get conducted through an aberrant pathway resulting in pre-excited ventricular fibrillation and irregular supraventricular tachycardias. So these are some of the illustrations for broad QRS complex tachycardias. So in the first illustration, you can see there is a paroxysmal non-sustained ventricular tachycardia. So you can see that there is a normal P wave followed by a QRS complex. Then immediately there is abnormal beat. You can see that the QRS complex has broadened and the QRS and T wave discordance is seen here. And the rate is very fast. So almost it reaches about 150 to 170 beats per minute. And then suddenly it terminates, only to reappear again in the third strip. So this is a paroxysmal non-sustained ventricular tachycardia. So the abnormal beat is originating from the ventricles, because of which it is having the abnormal morphology of broad QRS complex. It is nothing but, if you see sometimes on a normal ECG, you would have read that there is ventricular premature complex. So if you understand the characteristics of a ventricular premature complex, it is an abnormal beat which is originating from the ventricle. So if it's a single beat, it is not of much concern. But when we have a series of beats like that happening in a very fast succession, it can cause some amount of hemodynamic compromise, and it can even result in high mortality of these patients. So this is nothing but a series of such abnormal beats originating from the ventricles of the heart and beating so fast that the ventricles are unable to fill adequately and pump the blood to the body. Now, this is another lethal condition where we call it as a monomorphic ventricular tachycardia. When you see such kind of a rhythm, a wide QRS complex, like a design pattern, it looks the same from the origin till the termination. This is called monomorphic ventricular tachycardia, and these kind of rhythms you usually see in patients who have a massive myocardial infarction and patients who have electrolyte disturbances. And when you see such kind of rhythms, you should immediately give a DC shock to these patients, because these patients may not give you enough time to act and do anything else other than shocking them. So you can see the outcome. The moment this patient had a ventricular tachycardia, monomorphic ventricular tachycardia, a direct current was given and the rhythm got reverted back to normal sinus rhythm. However, the QRS complexes are still wide, but then the widening of the QRS complexes here is due to something else. Now, in the first strip here, you can see the cardiac arrest, a patient who is almost arresting. There is ventricular fibrillation. You don't see a definite pattern of a QRS complex. It is just like a sine wave, like some electricity recording, So this is almost a failing heart. When you see this on a monitor on a ECG strip, you should immediately jump up and start the cardiopulmonary resuscitation of these patients, because if you don't do a CPR for these patients, they will definitely not make it out. And in the bottom illustration, you can see another example of a wide QRS complex tachycardia. You can see that the QRS is wide, there is tachycardia, the rate is too high, 250 to 300. You don't see any P waves here. It's only the QRS complex. But you have to see that there is a peculiar pattern of the QRS complex such that it is almost twisting and turning around its own axis, like a helical structure. So when this kind of an ECG is seen while in an emergency, you should immediately think of torsady pose, and these patients should be quickly resuscitated. They should be given magnesium sulfate to immediately revert the rhythm back to normal. And these kind of tachycardias are common in patients who have long QT syndromes and those who have dyselectrolytemias like hypomagnesemia, hypocalcemia. Certain drugs can also cause torsades. I think a brief pause at here. Of late, you have been seeing that during the treatment of COVID patients, you would have heard patients using hydroxychloroquine and azithromycin, and you would have been hearing about the debates on how some people suddenly fell down and died while they were on hydroxychloroquine and azithromycin. So what happens is basically there are certain drugs in a medical practice, and being pharmacy students, you'll be knowing them better, that these QT interval and under the pressure of certain influences, patients can throw up a tachycardia like this. So having read about narrow QRS and wide QRS tachycardias based on the rate and rhythm approach, let us see what we can learn about the bradycardias. See, in bradycardias, if P waves are present, suppose if you see an ECG rhythm strip and you calculate the rate, and if you see the rate is less than 60, you have to see whether the P waves are present or not. If the P waves are present, then you have to ask the next question whether each P wave is followed by a QRS complex. If the answer is yes, then probably the problem is lying at the sinus node level, and it could be just a sinus bradycardia or a sinus node exit block or sinus pause or arrest. So basically the pacemaker isn't functioning properly, and that is the reason why the heart rate has come down. Alternately, you should also be clever enough to check the medications of the patient, because in today's world, where many of the elderly people are already having an episode of myocardial infarction and have received treatment, they may be on beta blockers. And sometimes elderly people who are having atrial fibrillation, they may be on rate controlling agents. So you should also check simultaneously the medications of these patients to see whether it is a drug-induced bradycardia or not. Now the next, once you've determined the PQRS relationship, now the next step that you have to assess is whether every P wave is followed by a QRS complex. If every P wave is followed by a QRS complex, then the answer is very simple. It could be just a sinus bradycardia or the other diagnosis as mentioned before. But if every P wave is not followed by a QRS complex, or if there is a pattern where some P waves are not followed by a QRS complex, then it helps you arrive at some of the diagnosis. So we have here a second degree AV block, a Mobitz type 1, where there is a progressive increase in the PR interval until a beat drops down completely. That is, if the PR interval of the first beat was 160 milliseconds, it may increase to 200, 240, 300, and suddenly there may be a P wave without a QRS complex, or there may be no P wave at all. Okay, then coming to the second type, the Mobitz type 2. In the Mobitz type 2, you have every P wave followed by a QRS complex, but at random, some of the P waves are not followed by a QRS complex. They are dropped. So both come under the class of second degree heart block. But however, if you question which is more lethal, you have to see that the Mobitz type 2 indicates that these patients are at higher risk of going for a complete heart block, who may require further evaluation. In second degree heart block, we have sometimes certain entities called 2:1 heart block or 3:1 heart blocks, where you can see that after every second beat or third beat, a beat is completely dropped or missed. A P wave is not followed by a QRS complex. So that also comes under the class of second degree heart block. The PR interval is very high, and on random, you have the PQRS complex missing. When you see such kind of ECG patterns, you should know that the patients are at imminent risk of developing complete heart block, where the impulses will never travel, the impulses which originate at the level of the sinoatrial node will never traverse across the AV junction and reach the ventricles. So they get completely blocked at the level of AV junction. They fail to reach down to the ventricles. So when this happens, there is no stimulus, and the ventricles will start failing to pump. However, under certain conditions, the human heart is designed in such a way that it maintains the hierarchy system. The sinoatrial node beating at 100 to 120 beats determines the heart rate of the the heart rate of the given person. But however, the nature has designed the electrical circuit in such a way that if the sinus node fails, the subsidiary pacemakers, that is the AV node, can take over the activity and then beat at a rate which is lesser than that of the sinoatrial node and still sustain the ventricular function. And the nature is so evolved that in case if the AV junction fails in propagating an impulse to maintain the ventricular activity, the Purkinje fibers and ventricular muscles sometimes itself can beat on their own, albeit at a very, very low rate, but still sometimes enough to sustain a life with some symptoms. So let us move on to the illustrations to understand these concepts. So here you can see that the QRS complex is normal. It's neither broad or narrow. There is a P wave which is followed by QRS complex. If you see the rhythm strip, that is the lead 2, which is located at the bottommost line of the ECG shown here, you can see that the first beat is having a P wave QRS relationship. Second beat is having a P wave QRS relationship. Third beat is having a P QRS relationship. And if you see, the PR interval is more or less the same for all these beats. But however, after the third beat, there is a sudden disappearance of a QRS complex. There is no P wave and no QRS complex. Okay, so this is one form of bradycardia. This is resulting in overall decrease in the heart rate. So this is another illustration. So you can, if you see the lead V1, V2, and V3, although it's not very clear in V4, V5, V6, you can see that there is a P wave followed by a QRS complex in the beat 1 and 2. However, the PR interval is quite prolonged until the beat completely disappears. So this is a problem which is happening at the AV junction. Okay, so there is a sinus node problem, and at the same time, there is a failure of conduction of impulse at the sinus node junction. Only thing, this ECG paper, if you see, it was taken at a higher paper speed, that is 50 millimeters per second. So if it was at a traditional speed, probably it might have been even more prolonged. So how do we analyze with these illustrations? How do we approach a case of bradycardia? So when you see a bradycardia, first you have to identify whether P waves are absent or present. If P waves are absent, are the junctional complexes narrow or wide? The QRS complex, is it narrow or wide? If it is narrow, that means still the impulse is originating above the level of ventricles and it is progressing through the natural circuitry and the QRS integrity is maintained. But however, the rate being slow, narrow QRS complex with absent P wave suggests that the subsidy pacemaker, which is the AV junction, is now the pacemaker of the heart which is generating the impulses. So in this illustration, we can see the heart rate is as low as 35 to 40. Now, some of you might argue saying that I can see a small P wave before the QRS complex. And if you have pointed out that, I would really appreciate for your keen observation, because this is a very important point here. Whenever there is a junctional rhythm, sometimes the atria can get retrogradely activated with the electrical impulse going backward from the AV junction to the atria, which results in negativity or inverted P wave in the rhythm strip. So if you see the bottom ECG illustration, you can again see there is a bradycardia, QRS is narrow, and there is no P-QRS relationship. P waves are almost absent. So this is again a junctional escape rhythm. Now sometimes patients can have bradycardia with wide QRS complex. So that means all the higher pacemaking authorities like the AV junction, the SA node, they have failed to generate the impulse, in which case the His bundle, the Purkinje fibers or the ventricles themselves, they have taken over the activity of pacing, which is called as a ventricular escape rhythm. You can see that the QRS complexes are wide and there is bradycardia and there are no P waves here again. So Now, coming to a brief summary of what we have understood on the rate and rhythm approach. So you could see that just by looking at the rate and the rhythm of the ECG, you could diagnose n number of arrhythmias. You didn't even have to proceed further to any other illustrations. So this is of very important clinical importance, because in casualty sometimes, or an emergency when you are there, and if you come across such kind of arrhythmias, it should not take too much time to diagnose them. So these 7-step approaches initially itself will help you diagnose the entity and act accordingly. Then you can see what are the other causes. Now, after analyzing the rate and rhythm, we go to the axis determination. Again, axis determination is a very, very tricky thing. Not many residents pay too much attention towards axis determination, but it is very important, because the axis determination helps us understand the electrical orientation of the heart and its chambers with respect to the coronal and sagittal plane of the human body. The normal axis is between minus 30 degrees to 90 degrees, 60 degrees plus 60 degrees. When it is beyond minus 30 degrees, it is called a left axis deviation, as you can see in this figure. And when the axis is beyond plus 60 degrees, it is called as a right axis deviation. However, when the deviation is on the extremes, for instance, if it is counterclockwise, that is negative beyond minus 90 degrees, it is called extreme left axis deviation. Or if it is clockwise going beyond 180 degrees, it is called an extreme right axis deviation, or the northwest axis. Now, axis determination is a very tricky thing. You have quite a few techniques, but I would suggest you stick to one of your own methods which you feel is very simple, not go by the sophistication to prove something. So we have a quadrant method for axis determination. I'm sorry, I think it's jammed, it's not moving. Yeah. So we have a quadrant method for axis determination, which is the most easiest in clinical practice, where we use only 2 perpendicular leads, that is the lead 1 and lead AVF. Then we have a 3-lead analysis where we use lead 1, 2 and AVF, the isoelectric method, and a rather more illustrative approach using a SAM technique just for the beginners. Okay. We also have what is called as a vector method, but that is only reserved for the electrophysiologists. And at the level of Pharma D, I would say that the first method, that is the quadrant method, is the most easiest. If you can stick on to that, the isoelectric lead analysis is also very easy. You can try that. Or Super SAM method, if you find it very amusing, yes, you can use that technique as well. So when we use the perpendicular leads, as you can, let's get back to the first one. You can see that lead 0, that 0 degrees is lead 1 and plus 90 degrees is lead AVF. So we have chosen 2 perpendicular planes of the cardiac axis, and we are using these 2 perpendicular planes to determine the orientation or the axis, electrical axis of the heart, the direction in which the electrical forces are moving. So if lead 1 is positive, that is predominantly positive, I'll again take you through the illustrations. If lead 1 is predominantly positive and lead AVF is predominantly positive, then the axis is normal, which falls anywhere between 0 to 90 degrees. If lead 1 is positive, however, lead AVF being negative, that means the axis is moving away from 90 degrees, but more towards lead 1. So the axis may be between 0 to minus 90 degrees, possibly the axis deviation. If the lead 1 is negative and lead AVF is positive, that means it is moving away from 0 degrees on the lead 1 and going more towards lead 3, then it is a right axis deviation. Now we have additional axis. Sometimes this simple straightforward method may not be adequate, and you may fall into confusions at some point where you may have to bring in additional axis to get an overall idea. But then this is quite complicated, and I would just skip this for now, because this would be beyond the scope of your understanding. So basically the principle is, if QRS is positive in any given lead, the axis points is, see the simple technique that I use, maybe I'll just make this more simple. The simple technique that I use is, when I look at the ECG, I'm using the standard leads. The ECG has got 6 standard leads and 6 chest leads. In the standard leads, we have lead 1, lead 2, lead 3, and the augmented leads, lead AVL, AVR, AVF. So when we are trying to determine the axis, we are using the standard leads, of which the lead 1 and lead AVF is what we are trying to use to determine the axis. Sometimes, to cut short the method, you can basically look at either, we group these leads as the left axis leads, which is 1 and AVL, and the right axis leads, which is 2, 3 and AVF. So among these two groups, we try to determine which lead has got the most positive QRS complex. That of R wave is the tallest, that is where the whole electrical force is moving towards, and that is the natural electrical axis of the heart. That is a rough estimate. So you, in an emergency situation, when you need to determine the axis of the heart, you may not have to waste time spending more and more time towards determining the axis. You can just quickly jump in and say, okay, this is falling in the normal axis range, or this is falling in the abnormal axis range. If the QRS is negative in any given lead, the axis is roughly the opposite direction to this lead. So that's what I showed you in the previous illustration. When both were positive, they were within the normal axis, but even one negative, it was moving towards the other axis, as you can see here. So in this figure, you can see lead 1 and AVL, 0 degrees and minus 30 degrees represent the left axis leads, whereas 2, AVF and 3, that is 60, 90 and 120 degrees respectively, they determine the right axis leads. So, and in this illustration, we saw that when the lead AVF was negative, the axis was moving towards left. So that is what the principle says here. If the QRS is isoelectric, suppose if you're stuck and you come across a lead where the QRS complex is isoelectric, which means that the height of R wave is equal to that of the depth of S wave in the QRS complex and that particular lead, then that is a null wave, null lead. That means there is no net deflection. So at this point, if you use your imagination of high school trigonometry, you can see that that is where the axis is perpendicular. So in the isoelectric method, we use one of these principles to find out what is the axis of the heart. So first we find out where or which lead has got the isoelectric point. That is, the height of R wave is equal to that of depth of S wave. And once we have found that, we see which set of leads, whether it is the left set leads, 1 AVL, or is the right set leads, that is 2, 3 AVF has got the positive R waves or the positive waves, and QRS axis naturally is going towards that particular direction. You would be able to understand these things if I show you the illustrations better here. So in this ECG, you can use two techniques. You can use lead 1 and lead AVF, and you can naturally determine the axis. You can see that in lead 1, the R wave is positive, the net QRS is positive. That is, the height of R wave is more than that of depth S wave. So the net QRS is positive. In lead AVF also, you can see that it is predominantly positive. So this itself will quickly give you a glance saying that by the first method, I know that the axis is normal. It is between 0 to 90 degrees. Now, how do you apply the isoelectric method? So here you can see in the isoelectric method, you see lead AVL, where the height of R wave is more or less identified this wave. Then you have to sort out the left axis leads and the right axis leads. So here the remaining left axis lead is the lead 1 and the remaining right axis leads is the 2,3 AVF. And you can see that lead 3 has got a very tall R wave. So that itself gives you an idea that the axis is more towards right or more towards 90 degrees. So it's the right axis. So as you employ more and more methods, your idea of getting to know the axis becomes very better. From a simplest method where you could say that it is not a left axis deviation, but it is electric method, you could go and say that it is more close to 90 degrees than that of 60 degrees. And if you use vector methods, you would be able to pinpoint the exact degrees also by using scales and compasses, which is more tedious, more for a research purpose. Now coming to the other illustration here in the isoelectric method. So you can see that the lead 2 here shows height of R wave more or less equal to that of the depth of the S wave. So when this happens, you know that lead 2 is the isoelectric point. So we have the remainder leads 3 and AVF, and which are the right axis leads, and we have the other leads 1 and AVL, which are the left axis leads. So you can see that when you have grouped these into two axis leads, you can see that predominantly in the left axis leads, it is positive. Right axis leads, it's positive. That is 3 and AVF are predominantly positive, whereas 1 and AVL are negative. So the axis is more towards right axis. So it is a right axis deviation. Similarly, you can see that the lead is predominantly negative in all the leads. Lead 1, lead 2, lead 3, lead AVF. They're all negative, and it's prominently positive in AVR and more positive in AVL, or maybe isoelectric in AVL. So if AVL is isoelectric, all the remainder leads negative, AVR positive, that means the axis is going counterclockwise. So if it is going counterclockwise, AVL being minus 30, so your axis is somewhere around minus 120 degrees, adding plus another 90 degrees to that. So when it is minus 120 degrees, it is the northwest axis. So it's an extreme axis deviation, which helps in identifying certain arrhythmias like ventricular tachycardia when you cannot differentiate between a ventricular tachycardia and an SVT with aberrancy. So now this is the last method, Super SAM, the axis man method. So this is more of a practical approach, maybe an amalgamation of all the techniques that we have discussed so far. So you start building a Super SAM man, the super axis man. You have a circle with the SAM's head on the top. And then you have the limbs, the upper limbs, which is the lead AVL. You dissect the circle horizontally, that becomes the horizontal axis, lead 1. And the perpendicular axis becomes your lead AVL. Now you draw the limbs, the legs become the lead 3 and lead AVF. So this is basically a diagrammatic representation of what I showed you in the beginning. So having seen this, AVR is the right limb, left limb is AVL. This is how we basically place our ECG leads in the body, and that's what we are trying to do here by diagrammatically representing the axis. So having done this, so we have marked all the leads, minus 30, plus 210, 0 degrees, 60, 90, and 120 degrees. And you have to find out the axis. Okay, so how do you find out the axis? We use the basic Pythagorean principle here to identify the axis, where the hypotenuse is the side. So how do you determine the hypotenuse here? It's John. Yeah. Uh, is it moving? Can you hear me?
Yes, sir.
Ah, I'm sorry. Actually, there is some net connection. Suddenly it's jumping. So we are using the Pythagorean principle to calculate the axis, where we find out the two perpendicular leads, calculate their net vector, and then draw the line to exactly determine the axis. Basically, this is nothing but the vector method, which is simplified by using a super axis man. And to determine the QRS complex, the amplitude of R wave and S wave, we are using those simple steps. So here you see the lead 1 and lead AVF, because these are the perpendicular leads. So in lead 1, if you see, QRS is net positive. And similarly in lead AVF, QRS is net positive. So we have 3 small squares for lead 1, and after deducting the 3 small squares of S wave from 12 small squares of height of R wave in lead AVF, we are left with 9 small squares, and that results in AVF 9 squares. So when you mark it, this is how it looks like. And when you complete that rectangle, the diagonal or the hypotenuse of this right angle is what becomes the axis. So this is a mere practical approach, more time consuming. In day-to-day clinical practice, it may be difficult, but this technique can be accurately employed for all the research purposes. So you have some of the illustrations. If you want, you can use them and try these. Many of these are available on the internet. So you can download and you can use some of these techniques to learn the axis determination. It's quite interesting and fun too. Now, let us start with analyzing of the ECG. Having determined the rate, rhythm, and axis, now we are going to step towards the more important aspects of the ECG, the understanding of the P waves, the PR intervals, the QRS complex, ST segment, and the T waves. So starting with the P wave. The P wave determines the atrial depolarization. So there are certain characteristics which have been laid down for as the properties of the P wave of a normal ECG. So if you see the P wave, again, as I described in the previous slides, has got three attributes: the duration, which is the amplitude, and the morphology or the contour or the shape of the P wave. So these are some of the characteristics based on those three attributes of a normal P wave. The P wave is best studied in leads 2 and lead V1. It is smooth and rounded in counter. The duration of the P wave is not more than 0.12 seconds or 120 milliseconds, which converts into 3 small horizontal squares. The amplitude is not more than 0.25 millivolts, which is roughly 2.5 small squares vertically. P waves should be always upright in lead 1 and lead 2. However, P waves can be inverted in AVR. P waves can be should be monophasic in lead 2 or biphasic in lead V1 and V2. Monophasic in the sense the P wave is present only on one side of the horizontal axis. When it is biphasic, that is, the initial deflection is positive, whereas the terminal deflection becomes negative by going below the horizontal axis, then it becomes a biphasic P wave, which I'll show you again in the illustrations. And these biphasic P waves are best studied in lead V1 and V2, which again has got clinical significance. So if the biphasic terminal negative deflection, it should not be more than 1 millimeter in depth or 0.03 seconds duration or 30 milliseconds duration. So some of the abnormalities, having understood this, so what are the abnormalities of the P wave? As we have already discussed about, one of these abnormalities is absence of P wave. So when the P waves are absent, it is called as atrial fibrillation. Now P waves can also be used to determine the chamber size. Larger the chamber size, bigger the P wave amplitude or the duration. Suppose if the patient has got biatrial enlargement, there is a particular morphology of the P wave. If there is right atrial enlargement, there is a morphology for a P wave. So these are the illustrations which will demonstrate that to you. So in the first figure, we can see that there is an absence of P wave. In the second illustration, on the right top corner, we can see that the P waves are normal. In the third illustration, on the left bottom corner, we can see that the P wave is biphasic. You can see that the P wave is both up and down, inverted. So that is a biphasic P wave. It is present both above and as well as below the horizontal axis. And in the last illustration, you can see that the P waves are much taller than that of the preceding T waves. So that indicates that there is a chamber enlargement. And when you see such tall P waves in lead 2, then there are two entities that you should think of. One, P mitral or P pulmonale. That is enlargement of the right atrial chamber due to either long-standing chronic lung disease or long-standing mitral stenosis. So once we have analyzed the P wave in its characters, then we move towards the next entity of the ECG, that is the PR interval. The PR interval is the duration where there is a brief pause of electrical impulses or brief slowdown, which is rather more appropriate term to use. It's a brief slowdown of these impulses at the AV node so that the atria have fully emptied into the ventricles and are now ready to receive the blood from the body and the valves to close. So there should be some amount of duration left between the emptying of the atria and the ventricles contracting so that the valves can close. So to facilitate all these orchestrated events, there is a brief relay of these impulses at the AV node between the atria and the ventricles. Which is termed as the PR interval. So normally the duration of this PR interval is 0.12 to 0.2 seconds, that is 120 to 200 milliseconds. If it is too short, it results in inadequate filling of the ventricles, and if it prolonged PR interval followed by heart blocks. So abnormalities of the PR interval, since it is just a duration which we are calculating on the horizontal axis, it can be either normal, long, or short. If it is short, it is called a short PR interval condition, and if it is long, it is called as prolonged PR interval. If usually more than 200 milliseconds is considered as long, less than 120 milliseconds is short. So conditions like rheumatic fever, ischemic heart disease, drugs like digoxin and quinidine, Lyme's disease, hypokalemia, all these things can result in prolongation of the PR interval to as much as from anywhere from 200 milliseconds to 300 milliseconds. Now, short PR interval, again, there are very few clinical entities, but of course of very great clinical significance because these can result in what is called as arrhythmias and sudden cardiac death. So short PR interval, when the PR interval is less than 100 milliseconds, it results in it can be either normal as a transient consequence of any dyselectrolytemias, or it can be pathological when it is called as an aberrant pathway or a delta wave, which we call it as WPW syndrome in clinical entity. Now, this prolongation of PR interval, as we have already discussed, it could be either first degree prolongation, where the PR interval is fixed, prolonged more than 200 milliseconds, or it could be a third degree where there is no PQRS correlation. Or it can also be a second degree heart block where we have where we have discussed about two illustrations, that is Mobitz type 1 and Mobitz type 2. As I said, in Mobitz type 1, there is a progressive prolongation of PR interval when a particular complex is completely dropped and not followed by a QRS complex. So this is what is called as a Movitz type 1, and we can see that here the PR interval is gradually progressing from one beat to next beat to third beat until the fourth beat is completely absent, followed by no QRS complex, and the whole cycle repeats again. So there is usually, when this happens, the location of the block is located at the AV node level. I'm sorry, I think. Yeah. So usually the location is at the AV node level, and the causes can be either dyselectrolytemia, drugs, toxins, myocardial ischemia, and so many other conditions. In the second illustration, we can see Movitz type 2, where at random or spontaneously, a particular PRS complex is not, a particular P wave is not followed by a QRS complex. So when there is a sudden appearance of a single non-conducted sinus P wave without features of type 1 block, you have to consider that this is a harbinger indicating of a severe conducting system disease, which can indicate either acute myocardial infarction or age-related degenerative changes of the conducting system, and the lesion is usually below the level of the atrioventricular node. So when it is below the level of the atrioventricular node, these patients can have serious consequences in the form of syncope, falls, head injuries, fractures, and so many things because of Stokes-Adams attacks. So these are the patients who are usually considered for evaluation and pacemaker implantation. So as I told you in the previous setup, this is an ECG for an advanced AV block, where you can see that on random, one particular P wave is conducted, but some of the P waves are missing. So this kind of an ECG is also indicative of an advanced AV nodal block or AV nodal disease. And these are again the patients who require evaluation for coronary artery disease and probably pacemaker implantation in the future. I think excuse me, sir. Do we still continue, or shall we take it to the next week?
Day after tomorrow will continue. Day after tomorrow.
Because we are halfway through.
Yes, sir.
So the next what I would be discussing is about the ventricles, the QRS complex, the ST segment, and how to diagnose the endpoints, and electrolyte disturbances. That's all, sir.
Okay, sir. Yes. Okay.
So shall we continue, or shall we leave it for next week, sir?
Next another 5 minutes we can finish it off, sir.
No, sir. I think it will take more than that.
Take on Thursday.
So just a quick recap of what we have done today. So we started with a brief introduction about the ECG and its implications in day-to-day clinical practice. We studied about the electrical events of the heart and what events produce the mechanical events in the heart, what electrical events, the significance of P wave and its correlation with atrial activity, the QRS complex with ventricular activity. And then we started reading about how to calculate the rate, rhythm, and its implications, the 7-step approach method to diagnose an arrhythmia quickly when you are encountering an ECG in an emergency by just using the rate and rhythm approach. And then followed by that, we learned about the axis method, where we focused mainly on two important techniques, that is the perpendicular axis lead method, that is using one and AVF, lead 1 and lead AVF, and then we also tried the isoelectric method. So whichever would suit a given particular scenario, we can use that to quickly calculate the axis. And we also studied about the right axis deviation and left axis deviation, and a brief introduction on extreme axis deviation. So after having understood these axes, we went and learned a little bit about the P wave, the abnormalities of P wave, and then we had seen some illustrations depicting the abnormalities of P wave, and we met after reading the normal characteristics, and then we quickly had a recap on the PR interval segment, its normal duration, and the conditions causing prolonged PR and short PR intervals. So in the next session, we will be discussing about the QRS complex, which is very important. The ST, the most important, because I know most of you would be looking towards the ST segment abnormalities to diagnose an acute myocardial infarction and how to identify, diagnose myocardial infarction in an emergency setting, especially when patients are complaining of chest pain and you're there to take an ECG or see an ECG, and then followed by abnormalities of T wave and how some of the electrolyte disturbances like potassium or magnesium can produce ECG changes. So this would in brief conclude about the ECG, learning of an ECG or an approach to understanding an ECG. Sir, over to you now. Sir? So do we have any questions for the session?
Hello, sir.
Yeah.
Sir, just a
I
second.
really thank the students for having patiently listening to me for the last 1.5 hours. I would be very happy if they have any doubts, they can leave a note here so that I can discuss before we can call for the day.
Sir, I have a doubt.
Yes, sir.
Sir, P wave indicates atrial depolarization. QRS
Yes.
complex indicates ventricular depolarization.
Yes, sir.
P indicates ventricular repolarization. So what
Yes,
about
sir.
atrial repolarization? Sir, how to identify atrial repolarization?
Excellent question, sir. Excellent question. Very few people would point that this critical point actually. In fact, the atria also depolarize. They depolarize and repolarize. But what happens is when the atria are repolarizing, simultaneously the ventricles are depolarizing. So when this is happening, the ventricular forces or the electrical forces of the ventricles are so large that the atrial repolarization waves are buried under the QRS complexes. That is the reason why you would not be seeing an atrial repolarization.
Sir, one more. Sir, one more
Yes, sir.
question, sir. Abnormalities of, in case of abnormalities of P wave,
Yes, sir.
tall P wave indicates what, sir? Widening P wave indicates what it indicates? Widening and tall.
Yes, sir.
P wave, sir.
When there is a widening of a P wave, we can have widening of the P wave when there is enlargement of both the atrial chambers, sir. For example, when we see a patient of mitral stenosis, when after a long duration, there is enlargement of the left atrium as well as the right atrium. And when this happens, we can see that the P wave not only increases in its height, but also in its duration, the width.
Okay, okay, sir. Yes.
Whereas when there is an isolated chamber enlargement, for example, more importantly, the right atrial enlargement, secondary to pulmonary hypertension, long-standing COPDs. So these patients are mitral stenosis, when it has progressed over a period of time, there can be only a single chamber enlargement where only the P wave, that is the height of the P wave, becomes very tall, which indicates that the right atrial chamber has dilated to a great extent. So when you are analyzing the P wave, the first half of because the sinoatrial node is located in the right atrium, so the first half of the wave, whatever you see it is basically the right atrial forces or the right atrial wave. The terminal portion of the wave, what you see, is the left atrial waves. That is why when you see the lead V1, you would see that there is a positive wave followed by a negative wave, because right atrium is located more anterior in the chest than the left atrium. So right atrium gives a positive deflection on the lead V1, from where it is recording, because lead V1 sits right along the right atrium, right, traveling towards the lead. So they produce a positive deflection in V1, which is much larger. And since the left atrium is located posterior to the right atrium, so when the impulses are reaching from the right atrium to the left ventricle, they are moving away from the lead, and the terminal portion of the wave becomes negative. And that is why we have set forth the criteria that the depth should not be more than 1 millimeter and the width should not be more than 30 milliseconds. If that exceeds, then we have a criteria called as a Morris index to say that there is a left atrial enlargement.
Thank you, sir. Dear student, do you have any questions? If you have questions, please leave message in chat box so that Karthik sir will address your questions. I hope there are no questions from our students, sir. Sir, excellent session, sir. You have given inputs about 7-step analysis of heart rhythm, heart calculation of heart rate, and widening QRS complex, and axis determination, and all explained very nicely, sir. I hope next session also very useful for all of us, and we learn a lot from your excellent talk, sir, from the Thursday also, sir. Thank you very much for joining with us.
Thank you, sir. Thank you very much. In fact, I would like to thank the audience also. I would like to thank Principal Sir, and I would like to thank
Definitely this overwhelming response, sir. Already the Zoom platform has exceeded 100, sir, and also there are many people are watching on the YouTube, sir, as well.
thank you, sir. I'm happy that it is helping many. I would really like to thank Vijay Kumar sir for creating such a platform to discuss a very important topic of ECG. I would like to thank the audience also. I would like to thank Principal sir. Thank you, sir. I'd like to thank
Overwhelming response, sir. Already Zoom platform has exceeded 100, sir, and also there are many people are watching on the YouTube.
Thank you, sir. I'm happy that it is helping many. I would really like to thank Vijay Kumar sir for creating such a platform.
End meeting to all. Close it.